I'm extremely delighted to be, here to inaugurate this series, the Cervilon Masterclass series today, with all of you. So thank you, all of everyone, for taking the time out to join us and, to be part of this, learning journey, because I think one of the most important things as doctors for us is to be, to keep ourselves updated. And knowledge is an ocean, and however much we learn, there is still more to be learned. And so I'm very, very happy and thankful to all of you that you have taken the time out on a Sunday to join us.
So today's session is decoding cervical spine disorders from symptom to structural diagnosis. It will help us to understanding symptoms to structure correlations, improve diagnostic accuracy, and enhance clinical decisions making in OPD practices. With this, I invite Dr. Kannan to take over this session. Welcome, sir.
First of all, I want to thank Dr. Ramesh Warrier for his kind words and Dr. Aditya for inviting me for this session. Okay, so as Dr. Aditya has said, I had done my BMS from Trivandrum Medical College in 1992. Then I did my MBBS and further did my D Ortho and DNB. So presently I am working as an orthopedic surgeon at District Hospital Kollam. And to be honest, my practice is now basically on towards the modern side, but I definitely want to come back to Ayurveda sooner or later. Okay. So with this, I think we shall start the session, isn't it? Okay. You can see my slides, isn't it?
Yes, Dr. Yes.
Okay. So the topic given to me is the disease of the cervical spine. And I would like to, basically concentrate on the modern aspects of that, and the Ayurveda aspects, I think, will be discussed later by an expert from your side. So the disease of the cervical spine, actually, it's a wide range of diseases, and it compromises a whole range from cervical spondylosis, cervical disc bulge, cervical spinal canal stenosis, cervical myelopathy, Arnold-Chiari malformations, atlantoaxial rotary instability, torticollis, syringomyelia, tumors and infections. So this is a very, very wide range. So I don't think it's possible to discuss all these topics in a session of 1 hour. So I'll basically be confining myself to cervical spondylosis, which is the most common disease that you encounter. And in the discussion of the cervical spondylosis, we'll be going into a little bit into the disc bulge, the spinal canal stenosis, the cervical myelopathy, etc., which are all part and parcel of this cervical spondylosis itself. The other thing, the Arnold-Chiari malformation, which is basically the herniation of the cerebellum, and atlantoaxial rotary instability, torticollis, etc. We can discuss it later, or if time permits, we can discuss it later. And coming to the traumatic aspects of the cervical spine, there are many known fractures and fracture dislocations other than the normal compression fracture and the burst fracture that you see in any part of the spine, including the cervical spine. There are these named fractures like the Jefferson's fracture, which is a fracture of the C1 vertebrae, and the odontoid fracture, the hangman's fracture, which is a traumatic fracture dislocation of C1 to C2, and the whiplash injury, and what is known as Shivora, that is spinal cord injury without radiological anomaly. Basically, if time permits, we will go a little bit into it, and I think we'll discuss a little bit about whiplash injury and spinal cord injury without radiological anomalies a little bit. I think that will be all that the time will permit us to do. Now, coming into the anatomy of the cervical spine. The anatomy of the cervical spine, as you all know, the cervical spine has seven cervical vertebrae from C1 to C7, and eight nerve roots are also present in the cervical vertebrae. The typical cervical vertebrae are from C3 to C6. C1 is an atlas vertebrae and C2 is an axis vertebrae, which are atypical vertebrae, and C7 is also an atypical vertebrae. The C1 doesn't have a body or a spinous process. All the spinal vertebrae are having a large foramen for the spinal cord, and they're having foramen for the foramen transverse area, which contains through which the vertebral artery goes in, and the cervical spine is having a lordotic curve. So this is the typical structure of a cervical vertebrae. The typical cervical vertebrae is also seen. Now coming to the structure of the intervertebral disc. The intervertebral disc, it's having a jellyfish candy-like structure. A jellyfish candy-like structure with three components. The first component is a nucleus pulposus. The nucleus pulposus is a central part of the disc. It bears about 75% of the weight transmission is through the nucleus pulposus. It is a remnant of the notochord and made of what is called as a chorda reticulum. It is filled with the synovial fluid initially and later by what is known as the Galler tissue. It is a jelly-like substance that is found in the disc, and it contains 88% of water. With aging, this tissue becomes less elastic and the water content decreases. So the first structure is the nucleus pulposus, which is seen in the center, which bears about 75% of the weight, and it is a jelly-like substance which contains about 88% of the water, and with the aging process, this water content will be getting decreased. Now we can see this in the MRI. When you see an MRI of an older person, you can see the dehydrated disc very specifically. It contains highly sulfated glycosaminoglycan, which are negatively charged, and which attracts positively charged solutes like sodium, which is responsible for maintaining the osmotic potential. So this glycosaminoglycan, the keratin sulfate and other things like that, which is present inside this disc, is responsible for keeping the disc hydrated. It attracts these positive ions like sodium, which gives it the osmotic pressure for keeping the disc hydrated and thereby turgid. In the aging process, you can see the glycosaminoglycan content will be decreased, and this decrease will cause the disc to dehydrate. The second layer, the outer layer actually, is the annulus fibrosus, and it contains highly cross-linked concentric layers of collagenous fibers, which lies obliquely, and it bears about 25% of the transmitted weight. Now this layer is important. This first thing, it is highly cross-linked, and it is lying obliquely, so that the movements of the cervical spine it remains intact in any movement of the cervical spine, be it flexion, extension, or whatever it is. And the end plate, that's also part of the disc, and it's made of hyaline cartilage on either side of the vertebral body, and it contains the lamina fibrosa, through which the diffusion of metabolic substance occurs. There is no blood vessels that transfers into the central layer of the disc, into the jelly-like substance. It is only the periphery that is having the blood supply, and through this periphery, the disc gets its nutrients by diffusion, and it happens through the vertebral end plate, the lamina fibrosa. So that's about the anatomical part of it. Now there is something called as the spinal motion segment and the tripod of the vertebral joint. there is a concept of the spinal motion segment. The spinal motion segment in a spinal segment, the motion actually happens between the intervertebral disc anteriorly and the two facet joints posteriorly, and this is known as a spinal motion segment, and it's compared to a tripod. How it is important is it is a tripod. So one leg of the tripod, if it becomes invalid, the other two gets into stress and it also fails. So if the intervertebral disc goes into a dehydration, if it goes into degeneration, it definitely affects the two posterior facet joints posteriorly, and that also goes into arthrosis later. So a degenerated disc of significant facial load, which typically precedes facet arthrosis. Okay, then there comes the concept of the dermatome. The dermatome represents an area of the skin supplied by peripheral nerves originating from a single dorsal root ganglion. And there's 8 nerve roots that are coming from the cervical spine, and the distribution of the cervical sensory nerve root is as mentioned here, is shown here, and you can see the thumb, which is being supplied by the C6, and the index and the ring finger being supplied by C7, and the ulnar fingers being supplied by C8. So this will be the distribution of the sensation from the sensory nerves. Now, how it is important is the paresthesia and the tingling sensation or the sensory loss happening in these distributions give us a clue into which segment of the nerve root is affected, and we can identify clinically which nerve root is affected by the sensory dermatome. This cervical spondylosis. Will get into the details of this of these things later. These things actually come in the course of the discussion. So, disc herniation. There are 4 stages in the disc herniation. The first stage will be a stage of protrusion, the second will be of prolapse, and third will be of extrusion, and the fourth will be a stage of sequestration. The first is the stage of protrusion, when the disc bulges without rupture. There is only a bulge in the disc. So there will be only an axial pain, there won't be any radicular pain in this stage. The second stage is the stage of prolapse, where the outermost annulus contains the nucleus and it's bulged. And the third is the stage of extrusion, where the disc material moves out into the epidural space. And the fourth is a stage of sequestration, where the disc fragments are lying independent from the disc into the canal. Now, coming to cervical spondylosis. Cervical spondylosis is a degenerative disease of the cervical spine, intervertebral disc, ligaments, and cartilaginous material. So it's not cervical spondylosis is not a disease of the cervical disc or the spine alone. It is a disc. It's a disc encompassing the ligaments, the cartilaginous material, the cervical spine, and the intervertebral disc in totality. It is commonly seen in individuals after the age of 40, but it can happen even before, which we'll discuss later. Believed to be a part of the normal aging process of the vertebral column. Some of those also include degenerative changes in the facet joint, longitudinal ligaments, and the ligament of flavor. So as I told, it is a degenerative process that is occurring all around the cervical spine in totality. Cervical spondylosis progresses with age and is often developed at multiple interspaces. Chronic cervical degeneration is the most common cause of cervical spinal cord compression and nerve root compression. Spondylotic changes can result in the stenosis of the cervical canal, leading to myelopathy, and the lateral recess and foramina, leading to radiculopathy. So, to conclude, as a result of the cervical spondylosis, you can have a compression either in the central part, that is the spinal canal, which causes the myelopathy, or the compression can happen in the lateral aspect, causing lateral recess or foraminal compression, leading to radiculopathy with pain radiating to the upper limbs. Now, coming to the etiology for the disc degeneration, the multiple etiology for disc degeneration, some of which we know and some of which we don't know. So, the reasons that we don't know will be put forward as idiopathic, and reasons that we know we are going to discuss. Aging. Age is the most important factor in disc degeneration. The second important factor will be the genetic factor. The mechanical factor is very important. Vibration, the use of vibrating tools, excess torsion, compression, trauma, everything is very important. Nutrition. The nutrition of the disc, basically. The calcification occurring in the end plates can cause end plate calcification, can cause lack of nutrition to the disc, causing disc degeneration, which we in MRI we can see the end plate changes very specifically in disc degeneration, and these things are actually proven. And smoking can cause ischemia to the vessels of the end plates, and that can cause lack of nutrition and cause disc degeneration. Toxic factors like smoking, metabolic disease. Some metabolic diseases predisposed to disc degeneration, especially diabetes, alkaptonuria, etc. And low-grade infections. Now, this is an emerging concept, like in gastric ulcer and things like that. But the pathology has been attributed in a majority of cases to infection by Helicobacter pylori. Likewise, in microdiscectomy cases, in some studies, the microdiscectomy specimen has been sent for culture and sensitivity, and in a whopping 84% of the cases, a bacteria has been identified, and Propionibacterium magnis is the bacteria that is identified, and there is a hypothesis now that disc degeneration can be due to a low-grade infection. So it can have, that can explain the disc degeneration that happens in very early ages in some people and very late ages in some people. And neurogenic inflammation. That is one hypothesis, that the inflammation of the nerve root causes a retrograde degeneration of the disc. Autoimmunity has also been proposed. Age is the most common cause in observed most commonly in elderly individuals. The disc degeneration is observed most commonly in elderly individuals. Amongst people younger than 40, 25% has degenerative disc disease and 4% have stenosis. In person older than 40, but 60% have degenerative disc diseases, and 20% has foraminal stenosis. So age has been well proved as a common as a cause of degenerative disc disease. Then trauma. It has a controversial role. Repeated subclinical trauma influence the onset and rate of progression of spondylosis. Now, rate of spondylosis and disc degeneration are very high in certain persons in having repeated trauma, like in boxers, and other people having repeated insults to the neck, and so a role of trauma has been proposed. And work activity significantly higher in persons who carry loads on the head than those who don't. So manual laborers with loading on their head load workers, actually, their X-rays mostly shows a very premature cervical spondylotic changes. and most of them have advanced cervical spondylotic changes in their X-rays. All of them are not symptomatic, although genetic. The role is unclear, but there have been many hypotheses about this, and there is a hypothesis that genetics is the most important reason, because uh, there are wide distribution in the age where the cervical spondylosis sets in. Some people are predisposed to have cervical spondylosis at a very young age, while some other people don't show changes of cervical spondylosis even in their 50s and 60s. So, a retrospective population-based study by Patel et al. Shows that genetics plays a role in the development of cervical spondylotic myelopathy, and people older than 50 years who have normal cervical spine are significantly more likely to have a sibling with normal or abnormal, normal or mildly abnormal radiological results. Coming to the pathophysiology, the indefatigable discs lose their hydration and elasticity with age, leading to cracks and fissures. The surrounding ligaments also lose their elastic property and develop traction spurs. So it starts in the disc where there is a loss of elasticity and hydration. I told you it's due to the loss of the glycosaminoglycan that happens in the disc. It's a normal aging process. It's just like you lose the pigmentation in your hair. Just like you lose your pigmentation in the hair when you grow old, the glycosaminoglycan content of your disc also decreases as you grow old, and this causes a loss of hydration. The disc hydration is decreased, and when the hydration is decreased, it actually its ability to remain turgid and keep the space apart decreases, and the elasticity is also decreased. These changes are then propagated to the surrounding ligaments, where their elastic properties are destroyed, and traction spurs. There will be spur formation in the surrounding ligaments that you can see in the X-ray as spurs. The disc subsequently collapses as a result of biomechanical incompetence, causing the annulus to bulge out. As the disc space narrows, the annulus bulges and the facets override. These changes in turn increases some motion at the spinal segment and further hastens the damage to the disc. I told you about the motion segments in the spine, comprising the disc and the facet joints. So once the disc fails, the stress is given to the facet joints, and the facet joints goes into synovitis, and it goes into osteoarthritic changes. So acute disc herniation may complicate a chronic spondylotic changes. That is, a person may be having a chronic spondylotic changes, and that can be an acute on chronic disc prolapse on this patient. Due to annulus bulges, the cross-sectional area of the spinal canal is narrowed. Once the disc bulges, it bulges into the spinal canal, and the cross-sectional area of the spinal canal is narrowed. The cross-sectional area of the spinal canal mostly is somewhere around 17, and in most of the cases, and this cross-sectional area of the spinal canal decreases once the disc bulges into the canal. This effect may be accentuated by the hypertrophy of the facet joint posteriorly and the ligamentum flavum, which becomes thick with age. See, as the disc bulges into the spinal canal, the spinal diameter is decreased. Together with it, I told you it is not only the disc that is getting degenerated, the surrounding ligament is getting degenerated. It becomes hypertrophied, and the facet joints are also undergoing changes, and there is a synovitis in the spinal cord, in the facet joints, that is also bulging into the space for the nerves, and all these things together will cause the space for the spinal cord and the spinal nerve roots to get decreased, and they go into compression. The next extension causes the ligaments to fold inward, reducing the anteroposterior diameter of the spinal canal. So in extension, the ligaments actually fold inward. The posterior longitudinal ligament folds inward, and that again causes a compression of the spinal cord. So these patients actually get relieved by stooping down. As the disc degeneration occurs, the uncinate process overrides and hypertrophies, compromising the ventrolateral portion of the foramen. Likewise, a facial hypertrophy decreases the dorsolateral. The uncinate process hypertrophy causes the ventrolateral portion to decrease, while the facet joint hypertrophy decreases the dorsolateral aspect of the foramen. These changes contributes to the radiculopathy and is associated with the cervical spondylosis. I think those are self-explanatory. This hypertrophy of the facet joints and the uncinate process and everything actually decreases the spinal diameter of the foramen as well as the spinal canal. The marginal osteophytes begin to develop. Additional stresses like trauma, long-term heavy uses may exacerbate this process. So this is a typical cross-sectional diagram, with the normal side seen on the right side and the abnormal side seen on the left side. You can see the spur formation, the disc bulges, everything causing the decrease in the spinal canal diameter as well as the foraminal diameter, and the compression of the spinal cords in the foraminal zone or in the central zone. Now, eventually, these osteophytes actually stabilize the vertebral body from increased movement. It's like just like putting a spinal jacket or a brace. The osteophyte stabilizes the vertebral body adjacent to the level of the degenerating disc and increases the weight-bearing area of the spine of the end plate, and the result is decreased effective force on each of these structures. This is the body's innate mechanism to stabilize the abnormal movement that happens with the disc degeneration. With the disc degeneration or with the spondylotic changes, there will be an abnormal movement happening in the motion segments, and the osteophytes and other things actually eventually tries to stabilize this thing. So what you see in the X-ray as osteophytes are actually the body's innate mechanism trying to stabilize the abnormal motion segments. Degeneration of the cervical joint surface and ligaments decrease motion and can act as a limiting mechanism against further deterioration. Thickening and ossification of the posterior longitudinal ligament also decreases the diameter. The posterior longitudinal ligament gets hypertrophied, and it gets hypertrophied and ossified also, and that also decreases the diameter. It's discussed a little bit earlier also. The blood supply of the spinal cord is an important anatomical factor in the pathophysiology. The radicular arteries in the dural sleeve tolerate compression and repetitive microtrauma poorly. The spinal cord size and canal size are also factors. A congenitally narrow canal does not necessarily predispose a person to myelopathy, but symptomatic disease rarely develop in individuals with a canal that is larger than 13 millimeters. So there are persons with a congenital narrow canal, and these persons need not predispose them to myelopathy. But the thing is, a person with a adequate canal, that is a canal, I told you the normal diameter is somewhere around 17. But a person having a canal more than 13 millimeter, symptomatic myelopathy rarely happens in such persons. The flexion of the cervical spine may lead to compression of the spinal cord against osteophytic bars, while extension may lead to compression against a hypertrophied ligamentum flavum. So we discussed this earlier, that in extension, the ligamentum flavum, hypertrophied ligamentum flavum, and the ossified part of the ligamentum flavum actually compresses the spinal cord, while in flexion, it will be the osteophytic bars that will be compressing more. The spinal canal diameter. the normal canal diameter on the lateral, canal diameter is measured on the lateral X-ray, and the lateral X-ray, the normal canal diameter on lateral X-ray will be from the spinolaminar line. From the spinolaminar line, you can see in the X-ray, you have the body anteriorly, and the lamina just posteriorly, and the spinous process still posteriorly. The spinolaminar line will be seen there, and the diameter will be from the spinolaminar line to the posterior vertebral body. You can see it from the X-ray. The spinolaminar line can be seen, and the posterior body can be seen. So the diameter from the spinolaminar line to the posterior vertebral body can be seen. It will be somewhere around 17 millimeter normally, plus or minus 30, plus or minus 5. So the normal will be 17 plus or minus 5. In the presence of osteophytic spurs, you have to measure from the back of the spur. If you have a spur in this X-ray, this X-ray is a normal X-ray, not having any spurs. So if you're having a spur, the diameter should be measured from the back of the spur to the spinolaminar line. The spinal canal stenosis various cutoffs for the normal minimum AP diameter has been suggested. Most authors agree that the stenosis is present when the AP diameter is less than 12 millimeter in adult. So the normal is 17 plus or minus 5, and the minimum that we should be around 12, and more than 12 you have to classify it as spinal canal stenosis. So pain from a degenerated disc disease, discogenic pain. Discogenic pain happens by the ingrowth of free nerve endings across the full thickness of the annular fissures. There will be tears in the annular layer, and there will be ingrowth of free nerve endings into that, and that will cause discogenic pain. The other cause of the pain will be the inflammatory cytokines. There will be many inflammatory cytokines inflammation going on, causing inflammatory cytokines in the vicinity, which will cause an inflammatory sort of pain. And there will be pressure on the nerve roots posteriorly, and facetogenic pain that will be from the arthros of the facet joint. So the pain in the cervical spondylosis actually occurs from multiple reasons. Actually, it happens because of multiple reasons. So first reason will be the discogenic pain due to the ingrowth of the free nerve endings into the torn annular fissures. There will be annular fissures occurring in the annulus fibrosus, and there will be ingrowth of new blood vessels and new nerve endings into the annular layer, and that causes the discogenic pain. Then there will be inflammatory cytokines that will be produced, and that causes an inflammatory pain. And this inflammatory pain is what we address with the steroids or with the non-steroidal anti-inflammatory drugs. And the pressure on the nerve posteriorly, the nerve gets pressed, and that causes a neuralgic pain to happen. And there will be a facet joint arthrosis happening posteriorly, which will cause a facetogenic pain. So the multifaceted pain will be happening in such diseases, and you have to address, first of all, you have to understand what sort of a thing is causing the pain. Is it the facet joint that is causing the pain? Is it the disc that is causing the pain? Or is it the nerve root compression that is causing the pain? To address it, and you have to address the cause for the pain, otherwise you will not be able to treat it. The course of cervical spondylosis may be slow and prolonged. They may remain either asymptomatic or may have a mild cervical pain. Long periods of non-progressive disability are typical. Few cases, the patient's condition progressively deteriorates. Both sexes are affected equally. This is about the cervical spondylosis. It will be normally cervical spondylosis will be having a very slow progression. Many will be asymptomatic. You take an X-ray of a cervical spine, it will show degenerative changes, but doesn't necessarily cause pain. And or it may have a mild cervical pain which the patient will be well adapted to, because it is a long duration of pain and the patient has time for adaptation for this, and the patient will take this as a normal routine. So that won't be an issue for the patient. So long periods of non-progressive disability are typical. That won't be an issue for the patient because it happens over a long period and the patient gets adapted to that. And few cases the condition progressively deteriorates that will need treatment, and both sexes are affected equally. Cervical spondylosis usually starts earlier in men than in women, and most commonly in individuals aged 40 to 60 years, and symptoms may appear in persons as young as 30 years. I told we discussed about the etiology, and we discussed that there are multiple reasons for this, and basically it's because of the glycosominogen content and genetic predisposition, etc. The morbidity ranges from chronic neck pain with radicular pain and diminished cervical range of movement, headache, predominant headache, which will be predominantly suboccipital headache will be there. Diminished cervical range of movement will be there. Myelopathy leading to weakness and impaired fine motor coordination, to quadriparesis and sphincteric dysfunction in advanced cases. So the morbidity have a wide range, can have a chronic neck pain. Most of it will be very mild and the patient will adapt to it. But in some cases, it will be on the upper side and it will have headache, which is predominantly suboccipital, with even they can progress to myelopathy with quadriparesis or quadriplegia in some cases, and sphincteric dysfunction in advanced cases. The common clinical syndromes which are associated with the cervical spondylosis will include cervical pain, suboccipital headache may be present. Mechanisms include direct nerve compression, degenerated disc, joint or ligamentous lesion, and segmental instability. Pain can be perceived locally or it may radiate to the occiput, shoulder, scapula, or arm. The pain in the cervical from the cervical spine actually radiates to the neck, and it can happen. It can reach up to the neck, that is the suboccipital region, or it can radiate to the interscapular region. It can radiate to the arm, to the shoulder. Now, you have to be very careful in assessing these patients, because a minority of these patients may be having other reasons for this pain, like they may be having a cardiac pain which may mimic a cervical radiculopathy, and it's prudent to take an ECG in cases where you have a clinical doubt. The pain will be worse when the patient is in certain positions and can interfere with sleep. So to conclude, actually there may be an overlap in many of these cases, because shoulder pain coming from frozen shoulder or from rotator cuff tendinosis or rotator cuff tear or things like that actually can mimic the cervical radiculopathy, and that has to be kept in mind. Even cardiac disease can mimic this pain, and that has to be kept in mind when assessing these patients. Cervical radiculopathy. Compression of the cervical roots leads to ischemic changes that causes sensory dysfunction, like radicular pain and motor dysfunction, like example weakness. So it's due to the compression of the cervical roots that the radiculopathy happens. Most commonly occurs in patients around 40 to 50 years. An acute herniated disc or chronic spondylotic changes can cause cervical radiculopathy or myelopathy. It can be an acute disc or a chronic disc or an acute on chronic disc. The C6 root is the most commonly affected because of the predominant degeneration at C5-C6 interspace, and it's the most common site is at C7 and C5. Next most common is at C7 and C5. So C5, C6 is the most common. So if you take an X-ray, most of the cases the changes will be seen in C5 and C6, and therefore the C6 nerve root will be the most commonly affected. Most cases of the cervical radiculopathy resolved with conservative management. Few require surgical intervention. So the cervical radiculopathy, majority of them, about 70 to 80% of them actually resolves by itself if you can support the patient for quite some time. Maybe it will take some 4 to 6 weeks normally, or sometimes it can carry on up to 3 months, but most of the cases resolve by itself by conservative management. It doesn't need any surgical intervention in the majority of the cases. There's a more serious issue, cervical spondylotic myelopathy, when the instead of the nerve root getting compressed, the cervical cord itself gets compressed. Most serious consequence of cervical intervertebral disc degeneration, especially when it is associated narrow cervical canal. So a narrow cervical canal can at times predispose. Insidious onset, which typically becomes apparent in patients aged 40 to 60 years. Complete reversal is rare once myelopathy occurs. Involvement of sphincter is unusual at presentation, but it can happen in advanced stages. So cervical myelopathy is a more serious issue compared to the radicular pain. It is due to the compression of the cervical cord centrally, and it causes the irreversible changes in the spinal cord, and that can cause quadriparesis or even quadriplegia and sphincteric dysfunction. So gait disturbance will be seen in most of the patients. You can ask, the people will be complaining that they have a drunken gait. It seems that the patient will have a very clumsy gait, and the gait disturbance will be one of the most common presentation. And in this series, spastic gait was one of the first symptom, followed by upper extremity numbness and loss of fine motor control of the hand. Other common symptoms of cervical myelopathy were neck pain as well as referred pain in the shoulder scapular region. Neck pain and the scapular pain, upper extremity numbness, etc., can happen in radiculopathy also, but in cervical myelopathy, because of the spinal cord is getting compressed, it can cause quadriparesis, and that can cause a clumsy gait of the patient. And upper motor symptoms will be seen, upper motor signs will be seen, the deep tendon reflexes will be exaggerated, Babinski sign and etc. will be positive. One-third of the patients with cervicalgia due to cervical myelopathy presents with headache, and two-thirds of the patients may present with unilateral bilateral shoulder pain. A significant number of these patients also present with pain radiating to the arm, forearm, hand, or with the long periods of remissions. Now coming to the physical examination, a decreased range of movement in cervical spine, especially with the neck extension, can be seen in cervical spondylosis. Hand clumsiness can be seen, sensory deficits can be seen, hyperreflexia of the lower extremity and in the upper extremity below the level of the lesion. Hyperreflexia is due to the upper motor lesion, happens in cervical myelopathy. A characteristic broad-based stooped and spastic gait will be seen. Extensor plantar reflex will be seen in severe myelopathy. Sperling's test will be positive. That's a radicular pain that can be exacerbated by the extension and lateral bending of the neck towards the side of the lesion. It's tested by the patient's neck is hyperextended and is laterally flexed, and you give an axial force downwards, and this causes the radicular pain to increase on the affected side. You can test it in both sides, but in affected side it will be increasing. Lermit sign, electric shock-like sensation associated with neck extension, can be seen in Hoffman sign. A reflex contraction of the thumb and index finger occurs in the response to the nipping of the middle finger. That is seen in the upper motor lesion. Imaging, plain X-ray, plain cervical radiography, routine in every patient in suspected cervical spondylosis, valuable in evaluating the uncovertebral and the facet joints, the foramen, intervertebral disc space, and the osteophyte formation. Flexion extension view may be needed to detect instability. If you see, normally we take only the AP and the lateral view. But if instability of the cervical spine is suspected, you have to take a flexion and extension view. So that will be the lateral view. The lateral view will be the most informative in the case of degenerative cervical spine. And this is a typical lateral view of a patient with a degenerative cervical spine, showing the spurs on the anterior aspect. The loss of the cervical lordosis is there. It's going actually for a kyphosis. The many displays are reduced, especially C5, C6 typically, and there are many spurs seen anteriorly and spurs seen posteriorly. Spurs seen anteriorly is not of much significance, but the posterior spur is more significant because it directly impinges into the spinal canal and into the spinal nerve root. So you have an X-ray with a posterior spur, it is very, very significant. Anterior spur is not, it's not that it is not significant, but posterior spur will be more significant than an anterior spur. Myelography with the CT can be used to assess the spinal canal and foraminal stenosis. Myelography is an invasive method when you have to inject dye into that and take a CT. So nowadays, with the advent of MRI, most of us actually depend on the MRI rather than the CT with the myelography. May be useful in visualizing the nerve root takeoff. CT scanning with or without interthecal dye may be used to estimate the diameter of the spinal canal. CTs may demonstrate small lateral osteophytes and calcific osteophytes in the middle of the vertebral body. But see, in MRI may be contraindicated in some cases where there will be a pacemaker in situ, or there is a implant in the near vicinity of the cervical spine, and you may have to go for CT myelography to detect these cases. MRI is a considerable advance in the use of imaging to diagnose cervical spondylosis with the following advantages: direct imaging in multiple planes, better definition of the neural elements, increased accuracy in evaluating the intrinsic spinal cord diseases, and non-invasiveness. That's the advantage of the MRI. You get very, very clear images with MRI. You can see the disc. You can see the disc getting herniated. You can see the disc impinging on the spinal cord. You can see the disc impinging on the nerve roots. You can see how the foramen gets decreased. You can see the myelopathic changes that is happening in the spinal cord, and you can pretty much see everything that is needed with an MRI. But the problem is false positive and false negative can happen frequently in patients with cervical radiculopathy. Therefore, MRI results and clinical findings should be used when results and clinical findings should be used when interpreting root compression. That is, see, you can have a patient with a radicular type of pain on the upper limb. I've seen many patients with that. Typical radicular-like patients, radicular-like symptoms. MRI taken and diagnosed as cervical radiculopathy. But when you see you have to learn to read the MRI, and you have to see which side is more affected. You have to see if it is the right or the left nerve root that is getting compressed, and you have to correlate it. A person with a radicular pain on the right upper limb, the MRI may be showing a disc more on the left side, compressing more on the left side. So that is a disparity by itself. You have to examine this patient more. Maybe he is suffering from carpal tunnel syndrome, or he is suffering from some other entrapment neuropathies, or he can be suffering from a thoracic outlet syndrome, or some other cause of nerve root impingement or nerve impingement may be there. And that has to be clinically seen, and you can end up in a soup if you treat this patient, or still worse if you go for a surgery just because there is a disc prolapse impinging on the nerve root. You have to first of all clinically examine this patient, rule out other causes of nerve root impingement before operating on a patient with cervical radiculopathy. So that's the problem with MRI. False positive and false negative can happen. You have to have a clinical eye before you conclude with the diagnosis with an MRI. T2 weighted hyperintensity at the level of the spinal compression has been shown to correlate with cervical myelopathy severity and has been supposed to be an important prognostic factor. Such findings are thought to be to represent edema and inflammation. So in the initial stages of cervical myelopathy, you will have a T2 hyperintensity in the cord. It can very well be seen in the MRI. The cord, which will be black in color, will have white strandings in the T2 image. So that is a sign of myelopathy. And on the other hand, T1 hypointensity has been shown to be a more severe sign representing ischemia, myelomalacia, or gliosis, may correlate with the post-operative worst outcome. That is, see, if you're having a hyperintensity in T2, that means there is edema in the spinal cord. If you're having a hyperintensity in T1, that means there is T1 is more towards the fat and T2 is more towards the water. So if there is hypointensity in T1, that means there is already gliosis that has been set in, and these patients will be having will have the worst prognosis even after surgery, because that is a irreversible change. So that will be an MRI of the patient with the cervical spondylosis. You can see the end plate changes happening in multiple intervertebral discs, the disc prolapse that is happening, and sort of hyperintensity in the spinal cord will also be seen. Studies involving the radiological investigation for asymptomatic individuals. So for even if you take a patient without any symptoms and take an X-ray of the cervical spine, 5 to 10% of the persons will be having spondylotic changes even at 20 to 30 years, 50% by the age of 45 years, and 90% by the age of 60 years. You don't necessarily have to treat these patients, because these are asymptomatic patients and X-ray can show spondylotic changes because of many reasons. So the prevalence of an abnormal MRI of the cervical spine as related to age is in asymptomatic individuals emphasizes the dangers of predicting operative decisions or diagnostic tests without precisely matching those findings with clinical signs and symptoms. Already discussed. Histology. There will be thinning and fragmentation of the articular cartilage. There will be normal smooth white articular surface becomes irregular and yellow. There will be loss of articular cartilage and fibrosis and things like that. Okay, I'm skipping that. Differential diagnosis. Differential diagnosis will be congenital Arno-Chiari malformation because of the herniation of the cerebellum. The tethered cord, syringomyelia. Syringomyelia will be having same features. Then acquired can be due to trauma, herniated intervertebral disc, kyphosis, extramedullary hematopoiesis, epidural lipomatosis, neoplastic like spinal cord tumors, carcinomatous meningitis, paraneoplastic syndromes. Anything that inside the spinal cord, inside the spinal canal, compressing the spinal cord, can cause the same symptoms as the disc or as a cervical spondylosis. So all these are actually differential diagnosis for this. It can be vascular like a hematoma or a spinal cord infarction, autoimmune like multiple sclerosis, infections, paraspinal abscess happening in TB, happening in infections like osteomyelitis, pyogenic discitis, tuberculosis, spinal meningitis, all can mimic the same thing. So a routine blood investigations, including blood routine CRP, especially has to be done in every patient with such conditions. Rise in CRP and rise in ESR and total count has to be viewed skeptically. Coming to the treatment of the cervical spondylosis, physical therapy. immobilization of the cervical spine is a mainstay of conservative treatment with the cervical spondylosis. Immobilization limits the range of movement, thereby reducing this nerve irritation. So, in the initial stages, when there is severe pain, you can give an immobilization, and immobilization with soft collar or with more rigid collars like a hard collar, even Philadelphia in extreme cases, can be initially helpful because it limits the range of movement and that reduces the symptoms initially. Patient's tolerance and compliance are consideration with any sort of braces used, especially when you go for more rigid immobilizations, compliance will be very less. A program of isometric cervical exercises to help limit the loss of muscle tone that results from the use of more restrictive orthosis. So once you give the orthosis, you have to start them on isometric cervical spine exercises too. Otherwise, there will be a drastic atrophy of the paraspinal muscles. Molded cervical pillows can better align the cervical spine during sleep and provide a symptomatic relief for some patients. So the use of molded cervical pillows is advocated. Normal pillows are not advocated because it causes extreme flexion of the spinal of the spine, and that can accentuate the compression. So you have to keep the spine straight, and also you have to give it support during sleep. So it's better to give molded cervical pillows where the cervical pillow is molded around the neck, around the back of the neck. So it gives more comfort to the patient during sleep, and the alignment is also kept. The use of cervical exercise has been advocated in patients with cervical spondylosis. Isometric exercises are often beneficial to maintain the strength of the neck muscles. The neck and upper back stretching exercise as well as light aerobic exercise are also recommended. Exercise programs are best initiated and monitored by a physical therapist. So that's the role of a physical therapist, a physiatrist in the treatment of cervical spine diseases. So passive modalities like application of heat by superficial devices like moist heat or mechanism of deep heat transfer like ultrasound diathermy. So we send the patients for CC therapy, they go for ultrasound, they go for gentle traction, they give and immobilization will also be given. So these are the isometric exercises where the patient resists in all the four directions of the spine isometrically, on the left, on the right, on the front, and on the back. These are basically for strengthening the paraspinal muscles. A mechanical traction is for this modality in physiotherapy where you give mechanical traction may be useful because it promotes immobilization of the cervical spine and widens the foraminal opening. However, traction in the treatment of cervical spine was not better than placebo. There are controversies regarding that, whether traction is effective or not. Some studies say traction is effective. Physiotherapists still do cervical traction for this, and even physiatrists also do cervical traction for that. But there are some studies that says that it is not better than a placebo. Manual therapy such as massage and immobilization may provide further relief of the patient with cervical spondylosis. So there is a role of massage and immobilization, and heat therapy is also advocated. Mobilization is performed by a physiotherapist and is characterized by application of gentle pressure within the limit of normal motion. The goal of increasing the ROM range of movement is severely decreased in cervical spondylosis. So mobilization under supervision has to be done by the physiotherapist. Manual traction may be better tolerated than mechanical traction in some patients. Occupational therapy. Occupational therapy is also very important because especially people with myelopathy, they will be going into severe loss of activities of daily living, and they may need occupational therapy also. So the drugs that we use normally will be steroids, NSAID, opioids, and drugs for reducing the radicular pain like carbamazepine, pregabalin, gabapentin, etc. So non-steroidal anti-inflammatories and the steroids, they act by inhibiting the inflammatory cascade. I told you that there will be a cytokine release at the site of these disc prolapse and at the site of the nerve compressions, and these cytokines will be causing the inflammatory cascade in the disc and in the vicinity of the nerve roots, causing inflammation, and this will increase the compression and the pain. So NSAIDs and steroids actually decrease this inflammation. So the compression that is due to the inflammation will be decreased, and also the inflammation decrease in inflammation also causes a reducing in the pressure. This is the logic of giving NSAIDs and steroids. So it's not just relieving pain, actually it is relieving the compression also with the steroids and the NSAIDs. And the opioids can also be given. And radicular pain. The radicular pain actually gets decreased by in most of the cases it gets decreased by about 1.5 months or 3 months of 3 months of treatment. Up to that time, some drugs to reduce the radicular pain like pregabalin or carbamazepine or gabapentin may be helpful. And steroids can also be given orally, or it can even be given as epidural steroid injections. And epidural steroid injections also they have a are very effective in these conditions, because that will give a continuous drug around the area of the inflammation for at least 2 to 3 months. So in advanced cases, that is very effective. With the non-operative treatment, approximately 75% of the patient have complete or partial but significant relief of the symptom. So that's the most important thing. All the disc, all the cervical spondylosis doesn't need surgical treatment. Most of them, actually 75% or even more of them, can get relieved even with the MRI showing significant nerve root compression, significant compression of the disc. They actually get relieved by a period of maybe 3 months or even a little more than that. So non-operative treatment may be effective in more than 75% of the cases. So non-operative treatment of cervical spondylosis with radiculopathy has not been compared to surgical mastectomy. So So this is about a randomized control trial that has been done, and the patient with the good outcome in conservatively treated group were of older age before treatment, had normal central motor conduction central motor conduction time, and possessed a larger transverse diameter of the spinal cord. So when they conducted this study, persons with this is about the myelopathy actually, people with the older age group and with a normal motor conduction time and larger transverse diameter of the spinal cord, actually they fared well with the conservative treatment. With the surgical treatment, patients with good outcome with surgically treated group had a more serious clinical picture. Conclusion was that the patient should preferably treat it conservatively if they have a spinal diameter of more than 70 square millimeter and of older age and have normally cervical conduction type. Surgery is more suitable for patients with clinically worse status and larger transverse area of the spinal cord. Surgical interventions. Indication for surgery includes progressive neurological deficit, documented compression of the spinal nerve root or the spinal cord, and intractable pain. An aim of the surgery will be to relieve the pain. Predictive factors for the outcome of surgery will be age, duration of symptoms, preoperative clinical status, anteroposterior diameter of the spinal cord, anteroposterior diameter of the spinal canal, area of the spinal cord, finding of hyperintense area, and that is myelopathy, one level or multiple level compression, congenital diameter of the spinal canal, etc. I'm not going into the details of the surgery, approaches for the surgery. I don't think you'll be interested in that. There will be, to put it in a nutshell, it will be an anterior or a posterior approach or a combined approach. It can be done with a laminectomy or a laminoplasty. I'm not going into the details of the surgery at all. So recent advances will be the endoscopic discectomy, when this disc can be removed with the help of an endoscope. There will be very small incisions, hardly 1 centimeter in length, and the whole thing can be removed with the help of an endoscope. It's a daycare surgery. The patient can walk into the theater, have the surgery done, and maybe walk out of the theater. Maybe they'll be discharged the same day or the day after. That is how things are evolving right now. That is about the endoscopic discectomy. And still recent advance is the disc replacement surgery, or the disc cervical arthroplasty, where the disc is removed and artificial disc is put in situ. See, the problem with the discectomy or removing the disc is you are losing the motion segment. You are losing the motion segment, and once the motion segment is lost, the movement in the disc will be transferred to the adjacent disc, and there will be what is known as adjacent disc disease that will be happening, and that is a complication in discectomy, whether it's lumbar discectomy or cervical discectomy. So adjacent disc disease can happen. So the adjacent disc can go into spondylotic changes, and it can fail after maybe 5 or 7 years. So to avoid that, an evolving treatment is what is known as cervical arthroplasty, where the a disc is removed and an artificial disc is kept so that the motion segment is kept alive. In previous days, actually, when you take out the disc, the motion segment is lost, and in sometimes you even fuse the disc to prevent instability. But in these cases, the instability, mobility is restored. But it's still evolving. I don't think it's done anywhere in Kerala right now, or very few centers in India does it. That's about the disc replacement. Now, prevention will be to avoid high impact exercises like running or jumping, maintaining cervical range of movement and daily ROM exercise. The cervical exercise has to be continued. Maintain neck strength, especially neck extensor strength. That is still with the exercises. Avoid holding the head in one position for long period, like driving, watching TV, computer work, etc. Avoid prolonged neck extension. Be careful while performing physical activities done frequently, such as activities that can trigger a flare in the symptoms. Cervical spondylomyelopathy, actually we have discussed a little about earlier also. Dr. Aditya?
Yes, doctor. Yeah.
Should we conclude here, or should we go into the cervical, a little bit into the cervical injury?
I think we can include that also, doctor. A little bit about cervical injury.
Okay. Yeah. So, cervical spine injuries, as I told, the cervical spine injuries, actually, there's a wide range of injuries that can happen in the cervical spine, from Jefferson's fracture, from odontoid fracture, from hangman's fracture, whiplash injury, etc. So Jefferson's fracture is a fracture of the C1, of a burst fracture of the C1. Then there will be the odontoid fracture, and the odontoid fracture will be the fracture of the odontoid process, and the hangman's fracture, which will be traumatic fracture dislocation, or listhesis of the C1 to C2. Now, they have their own classifications, and there will be all the three will be having their stable varieties and their unstable varieties. Unstable varieties will need surgery. Stable varieties can be treated with conservatively with immobilization, with rigid immobilization with rigid collars, or still better with what is known as a halo traction. We will see the halo traction later. Now, coming to the whiplash injury, we will discuss a little bit about the whiplash injury. The whiplash injury is caused due to a sudden deceleration. They are sudden deceleration injury. The head goes into hyperextension and then into hyperflexion. So sudden stopping of a moving vehicle will cause the whiplash injury. The head goes into hyperflexion and then into hyperextension. Sorry, I told in the reverse direction first. First it goes into hyperflexion and then into hyperextension because of the sudden deceleration. So this is how it will happen. First it goes into the hyperextension and then into the hyperflexion. Rupture of the interspinous ligament in the posterior side. So that will be the traction failure in the posterior aspect of the spinal cord, and the spinal ligaments on the posterior aspect actually gets avulsed, and there will be unlocking of the fascia joints. Fascia joints, I told, we have discussed that the fascia joints is in the posterior aspect, while the body and the disc is in the anterior aspect. So in the posterior aspect, the interspinous ligament fails and the fascia joints will be unlocked, and there will be a rupture of the disc or the fracture of the vertebrae can happen. That is a compression injury anteriorly can happen. So there will be a distraction injury posteriorly and a compression injury anteriorly. This is how it happens. So there will be a tear of the interspinous ligament. The interspinous ligament initially will be stretched and it will be teared later, and the fascia joints will be unlocked, and the disc will be the annulus fibrosus will be torn posteriorly, and even the body can get compressed. Due to compressed, there will be a compression there can be a compression fracture. Not in every cases there will be a compression fracture. Some cases there can be a compression fracture initially. So it's basically a cervical ligament injury due to the hyperextension and the flexion in sudden deceleration, and this will be what will be happening during impact. You can see it very well in the diagram. The posterior interspinous ligament getting torn because of the distraction, and then the fascia joints getting dislodged, and the spine goes into an unstable role. Clinical features: there will be severe neck pain and stiffness, may present with quadriplegia, but the X-rays will be normal. That is the most important thing. You take an X-ray for this patient, the X-ray will be mostly normal. So you may very well miss these cases. The patient coming to the casualty with a severe neck pain and stiffness, X-ray normal. You cannot send that patient home. The quadriplegia can evolve. He may not present with the quadriplegia initially, but later, the second day when you go for rounds, the patient will be with the quadriplegia. MRI may show the soft tissue injury and hemorrhage below the longitudinal ligament. See, even the CT may be normal in this case, but MRI can show these ligamentous injuries. May present with quadriplegia without radiological change due to the cord contusion. Treatment will be cervical traction, immobilization, analgesics, and wait for neurological recovery, because it's basically a ligamentous injury that is happening posteriorly. So rigid orthosis may be indeed like a Philadelphia collar or a halo. This is what is known as a halo vest immobilization. There will be the thing that is put on the forehead. The circular thing that is put on the forehead is known as a halo device, and there are pins actually from the halo device that is drilled into the one cortex of the skull to keep it there, and from there traction is given and it is fixed onto the on the vest like on the jacket like device on the body. It's known as a halo vest immobilization. So this is the thing that is given. Then there is something called the spinal cord injury without radiological abnormality. The spinal cord injury without radiological abnormality refers to spinal injuries typically located in the cervical region in the absence of identifiable bony or ligamentous injury on complete technically adequate plane radiograph or CT. So CT will be normal and the X-ray will be normal. So this will be basically happening in younger people. with neck injury. They will be coming with severe neck pain. It may be a child, so you think it will the child is fussy, but never actually underestimate this thing. This can happen. The X-ray may be normal. You take a screening CT, it may be normal. A trauma series CT may be normal. A X-ray may be normal, but still it can happen. Since the advent of magnet MRI, the approximately two-thirds of these cases described as scivora in literature actually have demonstrable injury to the spinal cord, soft tissue components of the spinal cord, of the spinal column. So MRI will be a better modality to pick this up. Because it's basically ligamentous injury, and you cannot send this patient home. You have to mobilize the patient, and you have to observe this patient. They can go for quadriparesis. Yeah, and if there is any neural deficit, you have to start them on steroids early itself. And there is a protocol for that. You have to start with medial prednisone injection if there is any suspicion for a neural deficit happening. Occurs more often in pediatric population, thought to be due to the elasticity of the pediatric spine. So in the pediatric spine, fracture of the spine may not happen. It may be basically a soft tissue injury that happens. In diagnosis of, it is a diagnosis of exclusion and needs MRI to evaluate for the cord edema and ligamentous injury. May have up to 4 days delay in presentation. Needs admission and observation. Keep the neck immobilized till improvement. Okay, so I'd like to conclude with this. Thank you.
Thank you, Doctor. Thank you, everyone. Hope you see you on the next Sunday. Thank you.